اوكي دوكي. طيب بسم الله الرحمن الرحيم. الحقيقه انا بشكر دكتور مازن ان هو دعاني ان انا اتكلم عن موضوع انا الحقيقه بحبه جدا. This is one of my very much preferred topic of teaching, which is post-keratoplasty astigmatism. For anyone who has been or is involved in corneal transplant surgery, the main problem, the main complication, the main flip side of corneal transplants is the post transplant astigmatism. Now, this is as equal in modern DALC surgery as in the good old penetrating keratoplasty era. Actually, in my hands, I have found that astigmatism post-operatively after penetrating keratoplasty, whether it is a manual keratoplasty or a femtosecond assisted keratoplasty, is much less, is significantly less than after doing a DALC. I think this comes from the fact that we have been, you know, oldies like myself, we've been seasoned in the training of penetrating keratoplasty. You get the hang of putting the graft, not overriding, not undermined, and this is, and to sort of equalize the pressure on all your sutures. And this has been you know in our training for years and years and years until it became second nature. But when DALC came, it's totally different dynamics, and the presence of the ballooning Descemet's membrane under you when you're suturing the corneal tissue necessitates that you put a lot of pressure, not you know like the very how can I say this, very gauged amount of force that we used to put when we did a penetrating keratoplasty. So it's a little bit of you know much more forced suturing. And if you see a successful DALC, usually at the end of the surgery, you will always find that the sutures are over tight, and there's like this gutter of or donut of the peripheral corneal tissue that indicates that you have done your job in the correct way. So if you do this, at the end of the day, you will end up with a bit of astigmatism. And
Dr.
DALC did
Mohammed,
not. Yes?
are you moving the slides? We are just still.
No, I'm not. I'm not. This is just an intro. So
Okay.
I'm sorry. No. Everything's fine. Everything's fine. So this is just an intro because I just want to say that if you avoid rejection, and if you get very crispy, clear, crystal corneas after a transplant, you cannot get away from the fact that you will end up with a little bit of astigmatism. So let's move the slides. So post-keratoplasty healing usually ends with corneal astigmatism. We all have our, our cases where you end up with a 0.5 diopter of astigmatism or 1 diopter of astigmatism, and you like the patient so much. But this unfortunately is not the norm. 1 year after surgery, the usual corneal astigmatism is in the neighborhood of 1 to 5 diopters, depending on the suture technique and the post-operative course. Some things are in your hands, which are the suture technique and the architecture or the design of the wound, but other things are not in your hands, namely the post-operative healing and the post-operative rejection if the patient gets any bout of rejection. So femtosecond PKP has dramatically reduced the amount of post-operative cylinder due to the innovative wound designs, less suturing, and smoother post-operative course. So when we take a look at this problem, which is very common, and we find it in almost all cases, you end up with a decent amount of astigmatism, then how can you manage it? So people have been addressing this since a very long time. And at first, there was the transverse keratotomies or the T-cuts. And then after that came the astigmatic keratotomies or the arcuate incisions. And classically, they have been done by freehand or with mechanized device, such as the Hana Architome, which was basically a fancy trephine that made only arcuate incisions only. And it had like a gauge protractor where it can actually stop for stop at the arc length that you design or you intend. But these old techniques, they had poor predictability, and the famous complications were wound gaping and, of course, perforations. The very famous nomograms was the Lindstrom nomogram, and this was very, very famous. It has been said, behind the scenes that Lindstrom orchestrated and designed the nomogram after doing only 9 eyes. So this definitely tells you why this nomogram was not that much popular and was not that much predictable. Before even the Lindstrom nomogram, there was the Hana nomogram, but these were very famous, but developed for native astigmatism, not post-keratoplasty astigmatism, because post-keratoplasty astigmatism behaves totally different than native astigmatism. Why? Because in native astigmatism, you need more incisional power because the cornea is made that way. So you need to sort of, defy nature and change this corneal shape. While in post-keratoplasty astigmatism, it's basically there is a little bit of fibrous tissue on one side more than the other side. So you can get away with just minimal arcuate incisions. Abbey did the nomogram for femtosecond astigmatic keratotomy based on Lindstrom, but again, this was for native astigmatism. And then the first developed femtosecond AK for post-keratoplasty astigmatism was by Humeric and Wu in 2010. This was the Hana nomogram. Now, one of the very, very important and very interesting and very, very efficacious nomograms that were designed to deal with post-keratoplasty astigmatism was the McGee and Buzard. Basically, they have shown that the arcuate incisions should follow the steep portion, the red part of your topography or your tomography. So if you have a lot of scarring on one side, so you just incise this scarred tissue and you end up with very decent results. Wilkins showed that the effect of astigmatic keratotomy post keratoplasty was proportional to the magnitude of astigmatism, which makes a lot of sense. Again, one of the landmarks. So the previous slide, the McGee and Buzard, this was a really a monumental or a turning point in the management of post-keratoplasty astigmatism, in the sense that if you incise the fibrous tissue, you will end up with very much decrease of the current corneal astigmatism. Now, the second landmark was the Toronto University. It was a multi-centric, it was actually 3 centers, but it was termed the Toronto University nomogram. It was very, very simple. It aimed at doing paired incisions, 60 degrees for 6 diopters, 70 degrees for 7 diopters, 80 degrees for 8 diopters, and so forth. So it was very easy. You don't need a nomogram to be stuck on the wall, and you can actually do it off the top of your mind without going back to books. And this was really, really effective post-keratoplasty. The recent ones are Travisky, and it's very, very, very efficacious as well. I've used it a lot. I'm actually using a combo between nomograms. I will explain later on in this presentation. And of course, the Sinclair et al. And this was published in 2016 in the Journal of Cataract and Refractive Surgery. This was the Sinclair's nomogram, and this was the Travisky. The Travisky was very smart in the sense that it only used 60 degrees of arc. So it didn't use anything more. And you played with this 60 degrees of arc according to the optical zone to get different effects of astigmatic correction. So going back to a different thing, to speaking on a different tone, topography-guided ablation, excimer laser can play a role in these patients where you get significant astigmatism after corneal transplants. It was originally introduced in the late 90s by Bosch and Lomb, something called the Topolink, which was basically a failure for the very simple reason that we didn't have any registration at the time, and the topographers were not that good. And so it depended on topographers that were not good, and it designed excimer laser ablations that were not regular and should be put on certain locations on the surface of the cornea. but it failed to apply this treatment on the exact pattern or exact place. So whenever you have a complex pattern that is not put in its right place, you end up with disastrous results. And this is exactly what happened. It never took off. It never flew across the Atlantic. It was a European venture, and everyone stopped. Indications for topography-guided ablation in this subcategory of patients is basically reshaping the irregular cornea to the best fit sphere and removing excess tissue to transform an irregular cornea into a regular cornea. This can be used in corneal scars, small optical zone decentrations, and of course post-keratoplasty. The modern topography-guided ablation, or the modern TCAT, or the Contura, improved exponentially. Actually, all refractive surgeons from my time, when topography-guided ablation in its modern facelift, may I say, came by, we resisted it a lot because we knew that the last time we decided to use topography as a guide for an ablation was a total failure. But to our surprise, actually, this has shown the best ever literature reported results in myopia and myopic astigmatism. It was unbelievable, but this is a different story with a different presentation. The TCAT main challenge is that while you are doing the TCAT, you actually induce a little bit of sphere, so you have to make sure that you're not doing this, and you apply what we call the topography neutralizing technique, not to induce any sphere. Okay, so if you have a post keratoplasty astigmatism, you have two weapons for the same enemy. Which one will you use more? And which one will you use first? This is basically the message that I will try to convene over the next few slides. I will do this by sharing with you guys a case report. This was a guy that I did a femtosecond PKP for in December 2014. He had an advanced keratoconus with high drops and central scarring, and we could not do a DALC. Actually, I never planned for a DALC in this patient. So I planned for a femtosecond keratoplasty using a mushroom, and it was uneventful. The mushroom design was 8.7, 7.4 donor, and 8.6, 7.3 recipient. The guy had an excellent recovery, very smooth recovery, and after only 2 months, traveled on his post-op medications. By the way, I stopped the heavy steroids, the heavy guns, like almost 1 month post-operatively. I use very low dose of low potency steroids like fluoromethalone after that. 5 months out after surgery, he presented with an attack of allograft rejection with a typical codeduced line tangential from 12 o'clock to 3 o'clock. And there was an accompanied suture-related inflammation in the same quadrant. The rejection was treated by suture removal, and we bombarded his cornea with steroids, gave him also systemic steroids, undercover with topical moxiflox for any bacterial suture-related infection. He responded very, very well, and signs of rejection and infection disappeared at all. But it left, a residue. It left signs. It left, battle signs, and these was in the form of that the area of treated inflammation showed moderate scarring. He was followed up regularly every month, and over the next 6 months, he had a very quiet eye, and the best corrected visual acuity was actually 6.9, which is 0.7. But take a look here. It was 6.9 with plus 275 sphere and minus 10 diopters of cylinder. And the reason that this guy had 10 diopters of cylinder was the fibrous tissue that happened over, let's say 3 clock hours of the graft because of the inflammation and the rejection and the infection that happened. The patient was, of course, very, very logically intolerant to hard contact lenses and to spectacles. We could not give him spectacles of minus 10 cylinders. So actually, the best corrected visual acuity is 0.7, but he did not wear any contact lenses or spectacles, so he never saw this 6.9. In February 2016, he presented to our office seeking a solution. He had an upcoming job interview in Dubai. This was in 2016. And let me share with you the tomography, the pentacam of this patient. So this patient had a good 9 diopters of cylinder. As you can see, guys, this is the part. This is the part where you have, that from 12 o'clock till 3 o'clock, the red part. This is the part that had fibrous tissue and was very, very steep and caused this astigmatism. This is the topography. Again, this is not the tomography. This is topography. In these patients, I cherish very, very much using a placebo topographer because the tomographer, as we all know, can interpret fibrous tissue or opacities as steepening, and this is something that we do not know, and we do not want. And by topography, he had a good 8.5 diopters of astigmatism as well. We decided to go for arcuate incisions on the femtosecond laser. Which nomogram to use? Most of astigmatic keratotomy nomograms are done for clear limber relaxing incisions at 11 millimeter diameters in phaco, like the Dono and the Napa nomograms. So we used a combination, and I will actually I will try to describe our recipe, how to combine these two nomograms. So it's McGee and Buzard and Numeric and Wu for a 7 millimeter optical zone. And this was our plan. Basically, the large arcuate incision was going to be done over the steep part of the cornea where it had the fibrous tissue, and the small arc, which is the 30. The big arc was 90 degrees of arc. The small arc was 30 degrees of arc, and they were going to be done 70% of pachymetry and with a femtosecond laser. Now, let me stop you guys here because at the time, this was, I think, in 2016, and at the time, it was propagated in all, publications and in all conferences that since we do have femtosecond capabilities of doing arcuate incision, then we do not need to open incisions to the top of the epithelium. So you actually do an intrastromal incision, and you'll end up with pretty much the same result as if you are doing a freehand incision or an arcuate incision that will reach the surface. So I believed in this, and I did exactly what everyone told us, that we do these incisions intrastromal. This was, of course, this is the patient under the microscope, so it's exactly a mirror image. And as you can see, there's a long arc, and on the other side there is the short arc. So what happened when we did this? Immediately post-operatively, we did the arcuate incisions. It takes like 2 seconds, and I sent the patients. It's intrastromal. I sent the patient down to the investigative unit to do a tomography, and this is what we got. Actually, he was 8.5. He started with 8.5, and he ended after the arcuate incisions with all this planning with 6.5. So actually, we lost only 2 diopters of astigmatism. Only 2 diopters of cylinder were corrected. So what to do now? Should we open the incision the good old way so maybe we can get more effect, or should we just leave it for a few days to reach its maximum relaxing effect, then reevaluate? I was really not very happy with the result because I thought once I do the intrastromal incision, the patient would go down and come back with a lot of astigmatism correction. I only had 2 diopters of astigmatism. So basically, I sent the patient back to the OR. He came to me back in the OR, and I opened the incision to the surface. Okay, it was to proceed and reopen the incision immediately or chill out for a few days and give the cornea a chance for remodeling. I did not chill out for a few days. I sent the patient back to the OR and opened the incisions to the surface. And immediately I got an augmented effect, only one more diopter of astigmatism. So the patient started off with 8.5 diopters of corneal astigmatism. And after doing the incisions and after opening the incisions to the surface, he had 5.5 diopters of astigmatism. So we lost 3 diopters of topographic cylinder. In manifest refraction, it was 4 diopters of astigmatism. Refraction of the patient became +1 with a -6 cylinder. Okay, but the good thing is the best corrected visual acuity now was 1.2, was not 0.7 or 6.9. It was actually 6.5. So he really felt improvement. But he and honestly, he wanted more correction. Now we started thinking about our other tool or other weapon, which is basically a topography-guided ablation. We decided to tackle the corneal astigmatism with the other weapon, which is the excimer laser. So we had a little bit of decisions to make. Should we use, obviously, topo-guided LASIK, or shall we use a standard optimized profile? Especially that the best corrected visually was visual acuity was 1.2, and we did not want fancy ablation in this cornea. Again, at the time it was 2016, and the results of the Contura study, FDA Contura study, was not out yet, and we did not have this, very good trust to the topography guided ablation. And this cornea had a track record of having a mind of its own. So shall I just go ahead and do, normal refractive surgery, or shall I trust the tomography guided ablation and do topography guided ablation? The second decision was in a patient with a PKP and a complex scar. This a patient had complex architecture because it was a mushroom scar, not a normal PK, and plus the fact that he had arcuate incisions. Should we do a surface ablation, or should we do a LASIK? And if we decide on a LASIK, shall we do a mechanical microkeratome LASIK or a femtosecond LASIK? These were all, debatable issues that we really had to think about. So our options was either to do a standard treatment like the wavefront optimized with a surface ablation, or a wavefront optimized with a mechanical microkeratome LASIK, or a wavefront optimized with a femto LASIK, or do a TCAT, surface TCAT with a mechanical microkeratome, or a TCAT with a femto LASIK. I would have definitely chosen TCAT with surface ablation, and this is what I would have chosen today. But the patient was due to travel in 10 days. He had this new job, and he didn't want this long rehabilitation, and he was really, enthusiastic. He wanted faster recovery. So I decided to go for TCAT and a femto LASIK. Actually, I don't know how did I get the guts or the courage to do this in this patient that we know does have more than one line of healing and fibrosis, plus the fact that he had arcuate incisions as well. So this was the plan. It was a nasal hinge flap, and it was actually an oval flap. And this was the pattern of ablation that we did. And this is what happened, ladies and gentlemen, after having 5.5 diopters of astigmatism. After we did this ablation, the patient ended up with 2.4 diopters of astigmatism. Okay. And with the topography, it was again 2 diopters of astigmatism. The uncorrected visual acuity, without anything, without wearing his glasses, contact lenses, or whatever, was 6.9. And the refraction was minus 1.75 cylinder. And the best corrected visual acuity with this minus 1.5 on 1.75 cylinder was 1.2. Patient was really happy. He was over the moon, and I was as well. But then he was a little bit greedy, and he asked if I would recommend further corrective procedure. We had the option of counseling the patient, advising him to wear his spectacle correction for the remaining cylinder and not to consider any more procedures. So that's it, hold the horses. Or to schedule the patient for an evaluation on the next holidays, on the next annual vacation, to prepare him for surface ablation to correct the residual cylinder. But this is what I told him. I told him that's it. I mean, you should not do anything more, because the enemy of good is perfect. Maybe if we go ahead and do another surface ablation on top of the flap in the cornea that has been transplanted and that has 2 arcuate incisions, we will end up with a nasty haze, and we will lose this 0.7 vision. So just to recap, this was our patient. He started off with astigmatism, 8.5 diopters post keratoplasty. We did an arcuate incision intrastromal, and he ended up with 6.7 diopters of astigmatism. We opened these arcuate incisions to the surface, and he ended up with 5.6 diopters of cylinder. And then we did our excimer laser TCAT, and of course, he ended up with 2 diopters of astigmatism. So our current routine plan for post-penetrating keratoplasty astigmatism is as follows. We do step number 1. We do a paired femtosecond assisted arcuate incision. And this is our recipe. This is what we do. We combine the Toronto and the Travisky nomograms as follows. And if you can, do a screenshot of this slide, because I think this slide is very useful in your practice. If you have less than 4 diopters of astigmatism, we do paired 60 degrees arcs. If we have 4.5, we do the same paired 60 arcs, but at a slightly smaller optical zone. In 6 diopters, we do paired arcs again at a smaller optical zone. And more than that, we increase the arcs. We do not go any smaller in an optical zone than 6 millimeters. But if we do that, if we have more than 6 diopters, we increase the arcs by 10 degrees per diopter, and then we see what we have. In cases with marked one-side fibrosis, we don't do paired arcs. We increase the arc length, and this is again another important slide, so please take a screenshot as well. In cases with marked one-side fibrosis, we increase the arc length on one side of the traction and decrease the arc length on the other side of the traction, exactly like what we did in this case, but preserve the sum of both arcs constant. After 2 months, we leave the cornea to sort of remodel and do the coupling effect of our arched incisions. And then after 2 months, we do surface topography-guided ablation with mitomycin to treat residual refractive error, cylinder being our primary aim. And our results are very encouraging. Actually, I supervised, when we started doing this, I supervised a PhD degree thesis, and we had absolutely fantastic results, and we actually published it. So I think in conclusion, post-keratoplasty astigmatism can compromise the result of very successful cornea, very, very crystal clear, accepted cornea. We have different tools to tackle this problem, combining femtosecond astigmatic keratotomy with topography-guided ablation, I think is a good mix. Femtosecond AK should be done first to relax the cornea and achieve maximum coupling. Then current FS-dedicated nomograms have markedly improved the outcomes. Thank you very much. By the way, I'm parking my car. I'm inside my car, parked in a parking lot, because I could not make the deadline of starting the Zoom meeting back home. So I thank Allah, Dr. Mazen, for this opportunity. Thank you, Dr. Mazen.
Thank you very much, Professor Hosny, for the amazing case and approach. Now, we will take some questions. Now, before we start, a question from my side. What was the time gap between the two approaches you did? Because as we understood from the case that the patient was in a hurry because he had an interview in Dubai. So it seems that you did the TCAT femtolasic very quickly after the AK, or what?
Yes. Now we have done 27 cases, 27 patients in the study that we published, and we found that the best results that we achieved was if we waited 2 months between the arcuate incisions and the excimer laser. This was an exceptional case that we've done. This is why I'm presenting this case, is that we did things that actually I wouldn't do today. For example, I wouldn't do a patient a femtolasic, and at the time, the rationale of me doing a femtolasic in this patient was that I did not want to use a mechanical microkeratome with an unpredictable, flap thickness or depth, because this patient had a penetrating keratoplasty and a wound. I would definitely compromise the biomechanics of this cornea, and he might end up with an ectatic graft, and this is something that really affects the quality of vision. So I wouldn't do. So that's why I did a femto flap, and I wouldn't do a femto flap. This patient, or this case, went absolutely fantastic, and I didn't have problems with patients from other colleagues that did a femtolasic too. But I think the safe bet is to do a surface ablation with the mitomycin. And in the cohort that we did in 27 eyes, the best results were in patients that we stopped for 2 months doing nothing, and then we re-evaluated the case and did the excimer laser topography guided.
How about the diameter of the flap? Was it just including the graft itself, or?
Yeah. This is. I was wondering, will anyone ask this or not? Actually, no. It was a regular flap that actually exceeded the. And I had my doubts: would the fibrosis or the fibrous tissue around the prevent the femtosecond laser from cutting or not? And will I get a flap that is distorted or can be torn? nothing happened really, Dr. Mazen. So I think these are things that we really, and we have seen this repeatedly because I have done penetrating keratoplasty using a femtosecond laser in patients that had not very clear corneas in corneal dystrophies and stuff. And the femtosecond lasers, which whatever the platform you're using, actually they cut very very well in these patients. So no, I had a normal flap, and the normal flap was dissected. I do not recall any difficulty in this specific case elevating the flap.
What was the thickness of the flap?
My flap thickness is standard 100.
Always. Okay.
Yeah.
Super. So you were very brave. 100 cutting through the interface, the
Yeah.
junction. That was amazing.
Yes.
Now, questions from the audience. Where did you do the AK? Did you do that on the junction or on the clear cornea, on the graft itself?
Actually, it was. I showed it on the slide. No, astigmatic keratotomies, by definition, should be done inside the graft. You
Okay.
never do it on the graft host junction. And as you can see, I did a very conservative approach by giving an optical zone of 7 millimeters. So all the other nomograms, they describe optical zones of 6 millimeters, 6.5 millimeters, 6.75 millimeters. And as we all know, this is much less than the diameter of an implanted graft.
Yeah.
So if you want the astigmatic keratotomy to be effective, you should always aim at doing the AKs inside the transplanted cornea, not on the edge, not on the wound.
Okay. Another question from the audience. They know that the AK has temporary effect. What do you think about this?
No, this is absolutely wrong. I will tell you right now, astigmatic keratotomy it is totally different from limbal relaxing incisions. Okay, this is totally different kind of fish because in limbal relaxing incisions you are tackling a cornea that has been created this way. So the cornea doesn't really want, there's no pull that you are going to relieve the cornea from. There's no pull. It's the way it's made. It looks, for example, like a watermelon, okay, like a rugby ball. So this is the, it's happy. So when you go to a rugby ball and do incisions superior and inferior to flatten the vertical meridian, for example, it will flatten, but again, you can end up with regression and not like toric IOLs. This is the very famous debate. If you have a patient with 2.5 diopters of astigmatism, would you go for a cat? And you're going to do a cataract. Would you do a cataract with a limbal relaxing incision, or would you pop in a toric IOL? And definitely a toric IOLs, they do have very long-lasting effects. So people translate or sort of project this principle on post-keratoplasty astigmatism. It's a totally different animal. In post-keratoplasty astigmatism, you have fibrous tissue that is pulling on the cornea, and the cornea is not happy at all. It is being pulled on. So what you're going to do is you're going to relieve this pull. So actually, I would be more concerned about ongoing increase of effect rather than regression in this specific patients.
Amazing. Another question. When you do the topo-guided treatment or even the wavefront guided treatment in such cases, do you follow the same rules for conus, for example? Is there any limit of ablation depth that you should not exceed 50 microns, for example, or something?
No, I don't. The only thing, no, because this is a very thick cornea that has been transplanted. It is not supposed to be ectatic. It's not supposed to be weak. The only thing that I do not do now, I did not do at the time, was that in Roberto Pineda and actually Sadir Hanoush. So Roberto Pineda is the one who started it, but now Sadir Hanoush is doing it as well. Is that in these patients where you have the indication of keratoplasty as keratoconus, they cross-link the whole cornea before doing the penetrating keratoplasty, whether you're going to do it with a femtosecond laser or you're going to do it manually. Why? Because I have seen this, you, Dr. Mazen, of course, have seen this, we all have seen this. Sometimes these patients, they have very excellent grafts and excellent corneas, but the residual corneal bed of the rim of the patient starts to become ectatic with time, because it is made of the same collagen that had a keratoconus before. So you end up with ectasia coming from outside the graft. And if you have cross-linked the cornea before doing the penetrating keratoplasty, this will not happen. Now, having said this, you have transplanted the cornea that is 600 microns in thickness and that is very, very thick. And the chap who died and you took the cornea from didn't have keratoconus. So no, I wouldn't obey the rules of topography-guided ablation. Like, for example, what I'm doing now is selective higher order ablation with ablations in the neighborhood of 10 microns, 15 microns, just to eliminate coma. This is a totally different thing. This is good old lower order aberration astigmatism. So it is not higher order aberration things. It's basically lower order aberration astigmatism, and you use it, you treat it like any astigmatism. The problem is, don't be overzealous or don't be greedy. If I have a patient with, I've done astigmatic keratotomy, I have 10 daughters of astigmatism. I did astigmatic keratotomy and I ended up with 5 daughters of astigmatism. I will aim to correct 3. I don't aim to correct 5 in these patients. I don't want to upregulate the keratocytes in a corneal graft that can end up with a little bit of activation of CD4 cells and invitation for rejection.
Amazing. Now you raised a question in my mind when you were talking about the recurrence of ectasia on the rim. Now, actually, still I have a doubt whether this is true or not, because in many cases, such apparent ectasia is because of bulging at the junction between the graft and the rim. And the bulging will be interpreted by any topography or any tomography as ectasia, while it is not. So is there any way to be definite that this is recurrence of ectasia on the rim, or no, this is bulging on the at that part of the graft? What do you think?
I don't have an answer to this question off the top of my mind, honestly, but I would think I would take a very good look at the tomography, make sure that there was no extrapolation, that the quality of the tomography was good. Why am I saying this? Because I will decide, or I will base my opinion on the looks of the tomography outside, let's say, 8 mm zone. And and I know that in a lot of tomographers, this is extrapolated. It's not super accurate. If I'm trusting my tomography, I will take a look at the area outside of the graft host junction and see if it is steep or not. But again, I don't have honestly a solid answer to this question, Dr. Mes.
Because what we know is about keratoconus is either central or paracentral. We don't see keratoconus which is very peripheral unless it is
Yeah,
PM. So in PMD,
yeah,
I do agree that we have to cross-link the whole cornea before doing anything. Yes, that's correct.
yeah.
Now the question, you said you would always prefer, whenever possible, to do surface ablation, topo-guided surface ablation. Is it trans-PRK or manual, or what do you do?
I haven't removed the epithelium manually for years and years and years. I always do a transepithelial PRK. Even before the era of Streamlight and Smart Surf and stuff, I used to do a PTK PRK regimen. I stopped using the amyloid brush. I think before 2010. Everything is transepithelial.
Yeah, that's great. Now, the last question, what is the role of PTK in such cases? When do you go for PTK?
PTK, I wouldn't think about PTK unless I do have an opacity. If I'm starting to get this fibrosis ends up in a nebulous cornea, especially in the visual axis or in the central optical zone, then I would definitely do an OCT to see the depth of this opacity and decide whether to do a PTK for this patient or not. But since we are only speaking about astigmatism, we presume that these corneas are transparent and that these corneas they didn't have any, central rejection, and that's why we are tackling this problem from with the mindset of the refractive surgeon rather than the mindset of the corneal surgeon.
Maybe I missed part of your answer. Let me make it clearer. If the cornea is very irregular, so in your case, the astigmatism was very beautifully symmetric, almost symmetric, and it had the bow tie. But let's assume that you cannot guess what the shape is. Irregular, hotspot here, hotspot there, flat here, flat there. So multi shape. So do you do PTK in such cases?
Now, these are totally different cases. Now, this is not a case of post-keratoplasty astigmatism. This is a case of irregular cornea that needs cornea repair work. So definitely, this is a totally different mindset, and I wouldn't do what I did in this case. I would resort to either a topography-guided ablation with tomography neutralizing techniques and coma, and start trying as much as possible to match the axis of the basic astigmatism or the primary astigmatism with the axis of the coma, and doing a tomography modified refraction, and trying as much as possible to smoothen this irregular cornea. Sometimes we used to use, back in the day, photoablative lenticular modulation, or you put some methyl cellulose and then do the PTK, and this definitely improved our results. But this is, this is how we use the excimer laser in smoothing an irregular cornea. But the main problem, Dr. Mazen, in these patients, if you have, like, 100 patients, all had beautiful penetrating keratoplasties coming for follow-ups over the months in your practice, you'll find, like, 95 of them, they have perfect grafts, very nice grafts, but then one of them will tell you, I don't think I've improved much. I'm not seeing that well. Why? Because he has a ginormous amount of astigmatism. And this is a problem that really I find in my practice, for example, that a lot of our junior colleagues are not dealing with it correctly. Always the doctor is on the defensive side. Your graft is perfect. You don't have anything, just use lubricants. But the patient is actually not benefiting from the very fancy, very nice, very expensive procedure that he had. So I think having in mind a treatment package in your mind for astigmatism should always be there. You have, for example, if you know that if the patient has, elevated intraocular pressure, you do have a paradigm in your mind what to do. So you always have to be ready with a ready-made plan that you can actually modify, but it has to be there if you're a transplant surgeon.
Thank you very much, Professor Hosny. Really, I enjoyed this session very much because I love the subject, actually, and you answered all my questions and the other questions of the audience as well. Thank you very much for your time, especially that you are doing this lecture while you are parking somewhere because of the crowded traffic
Yes.
in your city.
So there's always a first time.
Thank you very much, Professor Hosny, and have a
Thank you. Thank you, Professor.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam.